Your question is essentially, can we have open borders and a welfare state? That's the central
100.
political.
Yep.
Pow. I was able to find two Canadian doctors, to speak about the current state of affair of our healthcare system. And this story really was brought up by the Oakville family that lost their son, that are suing the Oakville hospital because their son literally died waiting on the doctor to do its job.
In early February of 2024, a migraine kept Finley home from school, but his condition got worse. Hazel took her son to Oakville Trafalgar Memorial Hospital just outside of Toronto. She says he would not see a doctor for hours despite telling the nurses Finley was not doing well.
When I went up at 3 in the morning, they said, well, we only have one doctor. But there's another one coming in at 4. I don't know where that one doctor was.
Finley was triaged at almost exactly 10 o'clock, and he wasn't actually seen by a physician until 6:22 in the morning.
According to the statement of claim about what happened that morning, the doctor said Finley was experiencing sepsis pneumonia with hypoxia, and he was at high risk for acute deterioration. His oxygen levels, which hospital records show had been dropping throughout the night, were a concern. Finley eventually needed to be intubated and also suffered a cardiac arrest. Finley was taken to Sick Kids Hospital in Toronto, but it was too late, as he was then in hypotensive shock.
We had to make the decision to take Finley off life support.
That opened up a massive can of bullshit because I started researching it, and I shared those numbers. I think it was on Tuesday, how they estimate that 8,000 to 15,000 people die in the ER waiting for a doctor each year in Canada. They say that the number could be as high as 28,000. That either way, I'm going to share them again. I want to bring them up, but I promised to do introductions, what I really, really suck at. So I apologize right away if I mess up your introduction. First, one of the two doctors we have on the show today is Dr. Chris Milburn. He has practiced ER, family and injury rehabilitation medicine for over 25 years. He has served as a medical education director and as a regional ER chief. He has a long history in medical politics, philosophy, and history. A longtime editorialist and radio commentator, Chris became the subject of college complaints because of his views, which ran afoul of the current left-wing stronghold on medicine. He and his wife, a psychiatrist, write a Substack called Paradox. That's pretty clever. I'm actually smart enough to understand what he means. So that's pretty clever. And he founded the Free Speech in Medicine Initiative. And second, we have Dr. Shawn Whatley, a physician and author of the 2020 book, When Politics Comes Before Patients. That's definitely something I want to read. And on the highly praised book on how to fix the emergency wait time in Canada, No More Lethal Waits. He has an extensive experience in healthcare administration and medical politics. Whatley is a past president of the Ontario Medical Association, OMA, and currently a Munch senior fellow in a health policy with the Macdonald-Laurier Institute. And I'm not sure monks. To me, a monk, I'm a martial art guy, so monks, they're shaved and they kick ass. So I'm not sure what a monk is. But looks like doctors, Chris,
guys,
Shawn,
how you doing? Thank you so much for being here.
Good to see you guys. Hey, I've never been introduced as Baldy before. One Baldy to another. So.
Hey, you fit in here.
I'm all there.
Yeah, look at this guy with Dr. Chris here with hair.
Yeah, what's going on?
It's usually a couple. It actually seems like a lot of our guests lately have been bald. It's just a bunch of bald guys shooting the shit. But we also welcome guests with hair as well, Dr. Milburn. So thank you guys for both being on here.
I appreciate your flexibility.
I guess you guys probably heard you can swear, you can say pretty much whatever you want. But the difference in the type of approach that we have is I'm a Christian conservative. He's what we call a common sense liberal, which I know doesn't make sense when you first hear it, but they still exist. But he doesn't believe that women can have penises. That's basically, that's definitely, that's what it is. So just to put a bit of context. Was that?
It makes me a far right Nazi apparently. So,
yep. So
I get that all the time actually.
So I don't know who wants to go first, but the whole idea that I had behind this is really the story that came out of Oakville, that family that lost their son because of the wait time, because of he was labeled as CTAS level 2, and yet from my understanding they're supposed to see a doctor within 95% of cases need to see a doctor within 15 minutes, and it took him multiple hours to see a doctor, and by the time they saw him they sent him to the Toronto Children's Hospital, and he ended up dying getting into a coma, and they had to unplug him. But that was the idea today, is to talk about what are those CTAS level, what is the triage that's happening in our hospitals right now, and what the fuck's happening? How are 15,000 people, 8 to 15,000 people dying every year waiting in the ER? How do we have tens of thousands of people waiting on dying on wait lists for surgeries? Like, what the fuck is going on here?
I just want to quickly add on to that, guys, before you answer. Just because when we did the show the other day, I thought those numbers couldn't be right. 8,000 to 15,000 in the ER, and then we're looking them up as we're going, and they were apparently. And I guess I wanted to add on to that. As you answer those questions, does that sound about right to you guys, or did that surprise you when you hear those?
Maybe I could start, and then because I'll lead into Shawn, who literally wrote the book on this, right?
Excellent. Yeah.
So I'm just kind of a pretender here, but what I'll say is, right from the beginning, when the story came out, I saw it being played out the exact same way as the story is being played out for 50 years in medicine. It's always the same thing. It's always, oh my God, how did this happen? We focus on the incident. The bureaucrats make more rules to make sure it won't happen again. And everybody goes in that same cycle. Most people jump up and down and say the government's not properly funding it, and we need to spend more money and throw more money and we need more managers to better manage things. How could this happen? And we end up back in the same spiral of doom that we've been in for decades. And really what I think it comes down to in my mind, and Shawn can expand on this, but it comes down to Canadians don't understand the difference between government-funded and government-run healthcare. We have a government-run healthcare system, which is, other than perhaps North Korea or Cuba, we have the most restrictive medical environment in the world. We stifle innovation. Getting private care is actually illegal. So I'm pretty sure we could have the Chris Milburn and Shawn Whatley emergency room, which would run very efficiently and would get people through, and people wouldn't die waiting. But we're not allowed to do that. The whole thing, it's a little bit of an aside, but the whole thing about CTAS levels, I think, is a distraction. In our emergency room, the big emergency room where I worked for many years, something like 25% of people are now a level 2 by the definition. Because if you look at the definitions, everybody's urgent. A kid with a fever is urgent. Somebody drinking a Tim Hortons and looking comfortable, but says their pain is 9 out of 10 and they need to be seen right away, they're urgent. Somebody with heartburn, and you know it's heartburn already, and triage is urgent. So they're all level 2. So you can't possibly see them all within 15 minutes. That's ridiculous. That's a bureaucratic rule. But anyway, I'll pass it over to Shawn and shut up there.
I'll just jump in then. So yeah, kudos to you guys for even tackling this topic. A few years ago, I was speaking with a health reporter from the Globe and Mail. I won't say which one. There's only a handful of them. And I said, listen, you got to do a story about this. We have our gymnasium at our hospital, very large hospital north of Toronto, packed with old people because we have no beds for them. We also have our auditorium packed with old people. We took all the chairs out, all the tables out, set up little curtains, no bathroom, a little more privacy than when they're in the hallway, but we filled it with old people. And a lot of these people are in various stages of dementia, and they're waiting to be placed in a nursing home. So I said, this is outrageous. This is not sanitary. There's carpets on the floor. And, when we get to a certain age, bowel and bladder function isn't. Anyways, you just let your mind run with the environment these people were being warehoused in. And the reporter, kudos to them. They were very empathic. They said, oh my gosh, this is terrible. However, our editor won't let us write a story like this. We need a new angle. maybe you could sneak me into the hospital and I could interview a patient. Or if the patient is too demented and unable to do an interview, maybe I could interview their family and get a human impact angle to this. And so if you look at the headlines over the last several years especially, it always has to be something even more outrageous. It's got to be a kid or a young person in this case, who was triaged as being very sick, but not seen for 7 hours. And then they died. And then the hospital's being sued. It's like you need 3 or 4 extras. But we already have so many stories that the public's not hearing about. Right before COVID, the city of Brampton declared a state of emergency literally the week before Canada declared the COVID pandemic, so in March. And they said we've had 4,300 patients cared for in hallways in Brampton Civic Hospital. So the
Wow.
town council voted unanimously to declare a state of emergency.
And this is before COVID?
Before COVID.
Wow.
Stories like a patient in Sudbury, Jelinek, brought this up in the legislature. She said, "I have a patient in my riding who was cared for 13 days in the Sudbury Hospital in a bathroom." And there were pictures, right? There was a toilet behind the end of the stretcher. Now, at least they had privacy in the bathroom,
Oh,
but we're always looking for one extra story to go
yeah.
over the top. And so building on Chris's comments, this is a lot of the same old thing we've been experiencing for decades.
But like I asked at the beginning, before you go, Rob,
Yep.
do those numbers, because those are the numbers that I have, and I did a lot of research. Like those numbers, I can cite the source. It's not just a post I saw on Instagram. I'm the one that made the post on Instagram. So I'm seeing, as per the report of the Canadian Journal of Emergency Medicine, they estimate that 8 to 15,000 Canadians die yearly in overcrowded emergency rooms. That as per the secondstreet.org, 15,474 Canadians died in 2023-2024 alone, waiting for surgeries or scan. And they say that the number could be as high as 28,000 as per the research that they've done by contacting the province directly and analyzing their numbers. That Second Street also says that over 70,000 Canadian patients have died on a wait list since 2018 to 2019. The number is more like 76,596. And as per the Fraser Institute, we're looking at it takes 30 weeks to see a specialist after being referred by a general practitioner, up 322% since 1993. And I made the calculation, but the average Canadian, our health system costs $9,500 per year per Canadian. That's the equivalent of $381 billion a year. Are those numbers, do they all make sense to you guys? Or can we all agree on those numbers, or are they out there?
Yeah, again, maybe I'll start and hand it to Shawn. Like, absolutely, this is my experience. I'm currently a rural family doctor. I do Emerge as well, but I see this from a number of different angles. I've been the head of Emerge for a region and kind of seen this all play out. So absolutely. So I watch people every day waiting for things, and some of them dying on wait lists. Or recently I had a man have a heart attack while he was waiting to have an angiogram, and he came into the hospital. He's in bad shape. He did make it, but he had a bad, terrible experience with all that and ended up with a damaged heart. So that's just like, to use a younger person's phrase, it's on the daily that we deal with that. And but it's very hard to put statistics on. So I'll tell you a quick anecdotal story. I came into my injury rehab clinic one morning. I was scheduled to see a patient, and I didn't see her in the waiting room. I asked the secretary, well, where's Mary? And she looked at me, and the secretary burst out crying and said, she died yesterday. I was like, oh my God, this woman, completely unexpected. She had developed chest pain while at our clinic. Physiotherapist had said, you need to go to the Emerge. And her response was, the last time I went there, I waited 8 hours. I'm not going again. I will not go to that emergency room. It's terrible. They're rude. I'm not going. And against the insistences of our physio, this lady decided to go home. the minute her relative saw her when she got home, they said, "Oh my God, took her, but she died en route to the hospital." Now, that's just one story. She's not going to show up in any statistics. She didn't die because of the healthcare system that she did. So how many it is, I think we can quibble over numbers. All we can say is that it's terrible that people have to wait for necessary services, and they clearly are in our system in Canada.
Yeah, great.
Yeah. So one thing, I guess
you want to let Shawn answer?
Yeah. Sorry, Shawn. If you had anything to add before I go on to the next question.
Oh, you can go on, man. I could add, and then you guys would have you wouldn't have a show. It would just be Chris and Shawn talking about data. So.
But do those numbers make sense to you? Are you surprised by those numbers, or does that sound right to you?
So I'm not surprised, and actually, I was involved in helping Second Street get that data that you're referencing, actually,
there you have it.
Yeah, so that data
not at all surprised.
There you go. So that data actually comes from Freedom of Information requests. So they gave FOIs to every province, and a lot of the provinces don't have data at all. And so when we were trying to figure out
the big range there, 8 to 15,000, that explains that.
Well, they are talking about the dying on wait lists. So Nico mentioned that number. And the trouble is we had to pick diagnoses where people actually would die from their diagnosis. So for example, if you die waiting to have your cataract surgery done, well, a lot of old people are waiting for cataracts, and then they have heart attacks. So it's not as simple as it sounds. And what we should be pushing for is to have hospitals keep better track of this data. They don't want to keep track of this data. And so kudos to you for calling it out.
Yeah, no, that's all I do. I'm hated everywhere.
Yeah, he just calls. That's all he does. Call shit out all the time, even when he's wrong. But that's actually really cool hearing how it works, because I think we all get a little dumbed down in modern society. We got those numbers just typing in Google, but you guys can't do that. You have to go through every single thing and make some judgment calls, I assume, and apply some knowledge. So that's actually really interesting. My question was, and one of the things that I like about this issue is because it's a really nice, a really good microcosm that I think shows off one of the strengths of this show. When we started it, we wanted to create a space for people who maybe weren't exactly fit in the left-right spectrum, just political orphans, right? Just people trying to come across, come together from all sides of the spectrum, just to talk about issues from a common sense perspective. And what we found is, obviously, I'm a liberal, or at least have liberal sensibilities. Nico's conservative. Is oftentimes we'll disagree on the solution, but we will very often agree on the problem. Which obviously, if we don't even agree on the problem, we can't even have a productive discussion. So when you apply that to this issue, we have covered this a few times, and one thing that where we seem to stand is we agree that there's a problem with the healthcare system. Nico's more conservative minded, so his solution is ditch the system, ditch the universal healthcare system, go to a more American style. As someone more liberal minded, mine is say, no, it is broken. We agree on that. Let's fix it, because I do like our system. I like the idea of a universal healthcare system. So my question to you guys is. And actually, before I ask that, there's certainly the perception that the system isn't working, that it's not giving us what we're supposed to have. Wait times are too long. People are dying. And I guess my question is, as people who are inside the system, is that your reality? Is that how you see it, that the system is broken? And if so, how would you fix it? I know it's a real fix would probably require many different things, but if you could distill it down to one or two things, like what would be the best ways to go about fixing it? Would you be more fix the system or more scrap it?
Again, Shawn, that's all right. I'll say a little piece about it. Yeah. So you made the fatal mistake there. You said that Nico wants a US style system. That's what Canadians always do. It's like whenever anybody talks about changing the system, like, you want a US style system. It's like,
he's a liberal afterwards. Like, after all, it's a liberal, so of course that's what I want.
The US has a system that people in Canada think that the US system is messed up because of the free market, but it's far from a free market system. The government there it's an incredibly regulated and top-heavy bureaucratic system. The government puts incredible amounts of money in through the DVA, Medicare, and Medicaid. So it's not at all like a free market system. Sure. So whenever, I think it's really important just to correct the thinking.
Yeah, no, I appreciate that, because I'm a layman on these issues.
To say that there are all these really good systems in the world. Sweden, Norway, Switzerland, Germany, all have really much better performing and less expensive healthcare systems. So the last thing that we want to get trapped in our thinking in Canada is, if we change our system at all, we're moving towards a US style system. Nobody ever talks about, oh my God, you say you want a Swedish style healthcare system, because it's a great system, but it's also a much less bureaucratic and much less government controlled system. It is a universal healthcare system in the sense that you get insurance through the government, but the government doesn't run healthcare. They don't have a stranglehold like they do in Canada.
So before you answer, Shawn, is that what you meant earlier by government funded versus government run? Like, you can have a government funded health system, but that could be privately ran like a business instead of having it ran by bureaucrats. Is that what you mean?
He's asking you, Chris.
Oh, no, yeah. Sorry. I thought he was asking you, Shawn. Yeah, absolutely. That's what I mean. I mean, like, you look at Europe, many of them have private systems. And as a consumer of healthcare, you have your government insurance, and you can pick your hospital, you can pick your doctor. They compete for your business because they want to give good service. Whereas in Canada, it's like, don't complain. You're only waiting like 3 months for your hip. Don't complain, while you're crippled with it, right?
Have you thought about having MAID?
We can get that in 1 month.
Right. So I think Chris nailed it when he said, who calls the shots, right? Is it the patient in charge, or is it the politicians and the government in charge? Now, when we say, oh, we're so different from the American system, actually in America, they have a third-party payer system. So the doc doesn't know really how much it costs. The patient doesn't know how much it costs, but the insurance company dictates whether or not you get care. In Canada, I don't know how much it costs. You don't know how much it costs. And a government bureaucrat dictates whether or not you get the care. Now, the nice thing about the Canadian, if we can say something nice about it, is that the bureaucrats aren't that motivated to be really cost conscious and that sort of thing. They take a blunt approach to whether or not you get access to your care. In America, these insurance companies are going to go broke if they aren't hardliners on some of the things that you're able to access. But both Canada and the United States, for the most part, is getting care. Patients are getting care on a third-party payer. So a third person is doing the paying. To answer your question, though, Rob, you said, well, how would you fix this? What can you do? Yeah. So I think both Rob and Nico, all the Baldies in the room here, and Chris, an honorable
Chris.
Baldy.
You're an honorary Baldy.
It's an honorary Baldy. We can all be very bullish on insurance in the sense that Canadians love insurance. We insure our cats, our dogs, our cows, our ATVs, our cars, our house. Anyways, we love insurance. And the case or the argument in favor of medical insurance, and not just a one-size-fits-all, but long-term care insurance and critical illness insurance and acute care insurance, the case for that is very strong. So whether you're liberal, conservative, NDP, whatever flavor you are, I think you're on pretty solid footing to say, yeah, let's support insurance. And to Nico's case, maybe Nico, it's very solid. I think it's not a non-conservative position to hold, to say, I don't want anyone dying in my country because they couldn't get care. So you should own that high ground. That, I think, is the moral high ground. We're going to take care of people in this country. We are pro-insurance. We are pro-helping people. But to your point, Rob, it's in the details. How do you actually get this done? And so you asked for solutions. I better stop there because I've said a whole bunch of stuff. I can offer 3-point solution on how to make it perfect if you're interested.
And can I interject one thing before Shawn comes back to that? Because Shawn, I should maybe say, I believe you're writing a book on this right now. Am I correct? Yeah. So
Shawn's writing a book on literally every topic.
That's right.
Literally writing a book on how to fix the healthcare system.
Yeah.
One of the problems with insurance in healthcare is, and I've written on this if people want to check out my Substack, but the idea of insurance, when you insure your house, you don't use your insurance to fix your kitchen when your countertops run out. You don't use your insurance to paint your house. You use your insurance when you get hit by lightning and your roof gets a hole in it, or when you have a flood. The healthcare insurance, as it was originally envisioned in the 1960s, was back when we thought of healthcare was actually, I think it's better called illness care. You got sick, your appendix got inflamed and you needed it out and you're going to die unless you get it out. Well, that's healthcare.
Yeah.
The problem is that healthcare is now morphed into everything. And the left wing of the political spectrum has pushed it into, well, housing is healthcare, because if people aren't housed, and nutrition is healthcare. So if people don't have good food, they're not healthy and whatnot. So now if somebody has problems with overeating and they want to be on Ozempic, guess what? You guys are paying for that. I'm paying for that through insurance. So basically, people now aren't using insurance as for the house insurance example. They're not using insurance when something bad happens. They want insurance for routine maintenance, my yearly blood tests, and I'd like my vitamin D level checked every 2 months and whatnot. And I will just, as an aside, say this is a real problem with a number of the immigrant cultures who are moving in. Once they know that healthcare is free in Canada, young, healthy people want constant checkups and blood work, a scan for this, a scan for that. And these people are incredibly expensive to the system. We're not equipped for that, because the doctors, we have this dual weird role, which kind of is two poles, where we're both the advocating for the patient, trying to get them good care, but we're also the gatekeeper to make sure that they don't use this care irresponsibly, because that impacts other people's access to it. So it's a difficult system. And I think insurance, the idea of insurance is great, but we have to define what is it for exactly.
Well, and you know, the cultural and political moment where it makes it so hard to have a real discussion about these things, because you know what will happen if you bring up that conversation in a meeting, and someone is going to say, oh, well, you're racist because you just hate immigrants, right? And that, of course, it's bad faith, but it does what it's designed to do. It shuts down the conversation. Why we can't have a healthy conversation about immigration policy? If your opinion is anything other than open borders, you're a racist. And of course, that's insane. We have to be able to talk about it if we can get to the right policy. So yeah, it's interesting that you brought that up, and it's interesting to see that people inside the system also see this as an issue as well.
Shawn, what do you think? You have a 3-point.
Yeah.
I wanted to hear that, Shawn.
You can change the system 3 ways.
3 ways. Actually, Chris read my mind, and he knew he absolutely nailed it when he said we got to talk about what we're covering. So insurance, yes, and that's my point number 2, life and limb. We need to refocus on things that are going to kill you or things that are going to lead to loss of your limb. Focus on that. Do a better job at that. My third point, and I'll tell you my first point when I'm done here. My third point is appropriateness, and Chris also mentioned that. Is it meaningful that we cover everything, every little bit of sadness, depression, grief, whatever? And I'm not hammering on that. I'm just saying when you get farther away from life and limb care, you get into a whole bunch of visits. Really popular right now. My kid has a hard time focusing in class, and so we get so many visits for patients who want their kid sent for a special assessment so that they can get an extra help in the classroom and extra time to do their tests. And so that's using a huge amount of resources. That's just one example. Sorry, moms and dads, for picking on you for that. But number one, the most important thing we need to do right now, and no one's going to do it, is to talk about who's in charge. Who's leading the boat? So we have the Fed saying, "Oh, listen, we're gonna pay 20 cents on the dollar, right? We offer a tip at the restaurant, and we get to call the shots. You provinces, you're not allowed to do this, or we might take away our 20% funding." And yet, in our Constitution, Section 92 of the Constitution Act says that healthcare belongs to the provinces. So the provinces and the feds have to work this out. Neither one really wants to work it out, because it's nice being a province saying, oh, well, if the feds paid more like they promised to do 50, 60 years ago, then we'd be fine. Yeah. So that's number one. Who's in charge? They have to figure out the governance problem, or we are going to be spinning around this forever.
One of the things that Rob and I have never spoken about this, and as much as I spend half my time in the US, so I understand what it is to be able to take a credit card out and my wife just gave birth, to be able to get a scan in the same day for about $80. Literally pick up my phone, show up 15 minutes, an hour later, I got an appointment, 3D print of what the baby looks like. When here, it took us 2 months when we came back to Canada, and we got that old 90s technology that almost needs to be lubricated in the back to work properly. But so I know there's a difference between the two. Obviously, we're very socialist in nature here in Canada. So moving away from the social system is not something that's feasible. The Overton window will never be there. It's never going to happen. But one of the things I would like to see happening, and I've never heard a politician, at least they don't have the fucking balls to talk about this, but we need to take care of the hypochondriacs out there. And we also need to put consequences on the patient. If you are obese and you keep on showing to the you keep on showing up to the hospital for troubles that are related to the way you treat your body, we should put them on a time frame to say, hey, here are all the resources that you can that you can ever need to lose weight. But if you don't lose weight within the next year, you're out. We're not protecting you anymore because you're not taking care of yourself. I'm a big fan of cigars, and you
or
know
at
what?
least maybe your lowest priority in the
No, there
feel-
needs to be. But hold on.
Okay.
There needs to be consequence. But this is where you and I disagree.
Oh,
I
agree
believe in
with
accountability.
consequences. I do
But-
agree on that, but yeah.
But there's need to be consequences and accountability that comes. Yes, we need to hold our government accountable. Yes, we need to hold the insurance company accountable. But to not hold ourselves accountable is bullshit, because we are a massive problem in a system that we believe is free. So I want to see, if you're a smoker, guess what? Your doctor tells you you're you're on the road of lung cancer. You don't want to stop. Well, fuck you. We're not gonna cover you. You want to play that game? That's fine. We'll charge you. Here's a bill. And then you can go American style and say, try finding insurance that are going to take care of you, knowing that you're on your way. Do you think that that's a possible? Do you think that that would be a common sense solution, or am I too crazy and I believe in accountability too much? We'll start with Chris and then we'll go to Shawn, because that seems to be the order now.
Yeah, that seems to be the flow of that story.
Yeah.
There's a great quote. The ultimate result of shielding man from his folly is to fill the world with fools. I can't remember who said it, but we have created a society where the nanny statism is so accepted 100%. Now that the idea that people don't know this, but provincial drug plans are more and more paying for Ozempic for people who are overweight.
That's insane.
Obese. Now, do I have a problem with people buying Ozempic if they say that, look, I really can't lose weight, I've tried everything, I'm going to buy Ozempic? I don't have a problem with that. Do I have a problem with the health insurance plan paying for that while my cousin waits on a wait list for his hip for 18 months? And he's disabled. I do. And so I just think the idea that the government should be all things to all people at all times is rampant in Canada. And it's really, really rampant, as evidenced by our attitude toward the healthcare system, that nobody should ever suffer any consequence of anything. We should take care of them. I'll give you just another little example. We had a lady who, there was a new treatment for Hep C a number of years ago. You can cure it. So we had a lady who was an IV drug user, very pleasant lady. I really quite liked her. She got the treatment. It was, I think at the time, $38,000 to get that treatment. That was paid for, right? 3 months later, she was back. She relapsed. She went back to injecting, and she had Hep C again. And guess what? We treated her again with another $38,000. So that's just like one blatant example of how much can we pay when people are really moths flying for the headlights. I don't know. It is difficult, and Shawn can comment on this too, but it is difficult to say we're not going to cover you because you did X, Y, Z. I think when people get sick, again, I don't want to live in a society where we let them die in pain. And there is, interestingly, there is some evidence that smokers are cheaper to the healthcare system because they don't live as long.
Yeah, I knew that.
It's pretty good data. So
here's another pack.
We might end up treating lung cancer, but they died at 53.
Just give out smokes at the doctor's office.
So, Nico, you asked the question, am I too crazy? I wrote it down. Quote, Nico, am I too crazy?
Yeah.
And the answer is yes, of course, man. Of course,
Well, we all knew that.
Obviously.
It was a circle. We already knew.
So I think the safe, I hate to use the word safe space, but the safe space in your question, Nico, is to separate horizontal equity from vertical equity. And these are just fancy words to say rich people versus poor people, or higher socioeconomic status, lower socioeconomic status. Everybody wants to frame this discussion in terms of rich and poor. Oh, Nico, so you're saying all the poor guys get no treatment because they're
Not what I said.
eating Doritos and drinking and smoking and they're not taking care of themselves. So you have to separate that out and say, okay, no, we've got Rob and Nico, and they are identical twins. They both earn the same income, 100,000, whatever it is, and they have the same genetics. But Nico works out like a fanatic. He's careful with his diet, and he ends up with a sore hip. Rob doesn't care. He's 400 pounds and doesn't take care of himself. He also gets a sore hip because you're both genetically predisposed to sore hips. And so I tell Nico, listen, we don't have to replace your hip right away. It's going to wear out over time, but you keep yourself neat and trim. Don't abuse your hip, go see the physiotherapist, blah, 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 blah. I say the same thing to Rob and he ignores me. And then Rob comes in every 2 months for the next 5 years saying, Doc, my hip hurts, and we're doing CT scan, referral to an orthopedic surgeon, another one. Nico, he gets one picture at the start and says, oh yeah, my hip's going to kind of wear out. My doc says I'm going to get a new hip in about 5-10 years. I'm going to try to prevent that. But Rob does the opposite approach. So that's horizontal equity. And you have to present it that way and say, now, is it fair that Nico and Rob are both paying the same health insurance premiums? And I think most people would say, no, Rob, you're totally abusing the situation. Why should you pay the same as Nico? And so if you frame it as a horizontal equity question, you'll get lefties and righties most of the times to agree that, yeah, that's not fair.
So one thing that's kind of coming up in this conversation a lot is, whether like Nico used the word hypochondriacs. I think Chris was just talking about, appropriateness and people who are going to so it seems like that is one of the issues. People who are, and I'm seeing in the comments a lot of people are saying a lot of the same things. Basically, people who are using it, the system, clogging it up for things they don't really need. And now, as in Nico's example a minute ago, I agree with what he's talking about. I like the idea of some sort of accountability. I think denying service to people would probably be unfeasible. But is there any feasible solution to inject some amount of accountability in the system to get people to, whether it's a small deductible upon a visit or something like that
or a
could be
reward
perceived,
for the people that are healthy instead
tax
of
break
taking away,
maybe? Yeah.
if you're healthy, if every year you pass and you're taking care of yourself, you're eating well, you're hitting the gym, you're exercising, you pay less.
Yeah,
but there has to be a way, right?
One of the show's themes is solving problems. So is there a way that we could feasibly solve this problem? Even let's say you have like maybe a pie in the sky idea that we would never do. I'd be interested in that. But also if there's an idea you think that we actually might be able to do.
Chris?
And I guess start with Chris and then.
I'll let Shawn start because he's thought a lot more about these particular questions. So.
Yeah. So you guys are asking about patient cost sharing, and that's a whole, a couple textbooks out there that you could read just on that topic alone. The problem with Canada when you talk about patient cost sharing is we already have about 27 roadblocks between you and your access to care. You wait in line at the emerge, you wait in line at the lab, you wait in line for the CT. You're supposed to get an MRI, but you only get a CT, on and on. We are so roadblocked and rationed already to now say, oh, we're going to add another roadblock for you. If people are just like, it doesn't make sense. Forget about it. Having said that, when you talk about patient cost sharing, there are 32 healthcare systems around the world that have universal insurance. 28 of those, the last time I checked, have some form of patient cost sharing. So think of the most socialist country you can imagine. Everybody picks Sweden. They have last time I checked, it was about $300 deductible that you had to pay for family doctor's visits for the year, similar $200 to $300 deductible for the year for medications. And talking about vertical equity again, rich and poor, the very poor, the old, the sick, the elderly, there always are exceptions built into all of these patient cost sharing approaches. Now, the first answer from folks maybe on Rob's end of the spectrum is to say, well, that's so administratively expensive to do that. And he's right. It does cost money. You aren't doing this as a way to save money. You're doing this as a way to direct limited resources to the patients who need it the most. That's why you're doing it. You're not doing it to make money.
Do you guys have time to answer one more question? Like, I know you guys were supposed to be done at 1. It's 1:06.
I'm not in a hurry. I'm good.
Yep.
Cool.
Shawn?
Cool.
Yep.
Shawn?
Good.
This is a question. You thought my last one was bad. This one is going to piss people off. But one of the things that we talk about all the time here is the cost of our immigration / asylum seekers / people that never participated in a system that gets to take advantage of it. Now, people don't realize that we have a lot of foreigners in Canada, a lot of people that become permanent resident, a lot of people that are asylum seekers. Like right now, it's estimated that we have anywhere between 175 to 300,000 of them right now. And obviously they get
hearing.
Yep, but they get health. Yeah, they're awaiting on the decision that can take 17 months to 2.5 years. We give them healthcare. So do you think that there should be a time of contribution needed before a newcomer to Canada is capable of taking advantage of our health system? Chris, you seem to be excited about that one.
I am excited about this, so I'll go. Yes, I totally have run into this situation. Discussed it a lot with doctor friends recently. So if you go back, I can't tell you exactly how long, but say 15 to 20 years, newcomers, you're not allowed to say immigrants anymore because it's racist somehow.
I don't care. I'm racist from the get-go. I'm a xenophobe, racist Christian, so it's all good.
He isn't actually, but he just doesnn't care about the.
I know. People, it took a while to get health insurance, right? There was a lockout period, and I believe that's being shortened officially. I believe that people get health care numbers very quickly now and get free healthcare. But when these people were in this period where they didn't have health insurance, when they showed up at a hospital or a clinic, doctors could choose to treat them or not. If you showed up and you wanted to get seen because you had a rash, like clinic, but you didn't have health insurance, I could say, yeah, well, I'm going to charge you whatever, $20, $50, whatever. And if somebody said no, then I wouldn't have to treat them. But then, so what happened was these newcomer clinics or immigrant healthcare clinics got set up. And at first it was doctors volunteering out of the goodness of their heart, say, well, these people are, hard done by, so I'm going to take a half day once every 2 weeks and go and volunteer at the clinic. And I thought that was great because it placed a natural limit on the amount of healthcare. So the little old lady who had paid taxes in Canada for 70 years and now needed healthcare, she could get the government-funded healthcare. The immigrants could get healthcare when the clinic was open 1 day a week or whatnot. But then, over time, the doctors who worked these clinics pushed the government, and the government started to fund these clinics. So I don't know about other provinces, but in Nova Scotia now we have newcomer clinics that are government-funded. The doctors are getting very well paid, and some doctors are not working as much in the normal system now. So that 78-year-old lady doesn't have a family doctor, but as a newcomer, you have better healthcare funded by the government, and there's no limit on it. And the doctor gets the social credit for, look at me, I work at the newcomer clinic. People don't realize you're not volunteering. You're getting really well paid, probably better than if you were just a regular old family doctor. So there's a real problem here that the new immigrants are actually getting preferential care where I am compared to somebody who's actually just a regular old Canadian.
Wow.
And by the way, Rob and Chris, you're from the same place. If I'm not mistaken.
Oh yeah, I grew up in Halifax as well. I'm actually heading there.
I'm a Cape Bretoner, so. Oh
yes, yeah. I'm a mainlander, so
So you're.
I know you couldn't help it. Sorry.
So you're lucky. Chris, he's not going to show up to your clinic.
Okay.
Well, Chris has toned down his bars and cars, and we haven't heard much of that there.
I speak very properly now.
Yes, you do. Yeah.
Now.
So your question is essentially, can we have open borders and a welfare state? That's the central political.
Yep.
Pow. Exactly.
Yeah, that's what it is. Can we have a welfare state and open borders? And so the question isn't not, okay, we have these people in and they're going to get care, but they're not going to get care. We're going to make those other people wait very long. And we don't really want old people because they haven't paid taxes their whole life. Like all of that stuff that ends up being almost impossible to sort out starts from that first presupposition. You have a welfare state, then you can't have open borders. And if you can't have open borders, then you got to get your immigration figured out ahead of time. And we're not doing that. We're inviting them in and student visas and refugees. And by the way, we can't even take care of the people that we got. But here's another however many, you guys know the numbers. I don't know, it's 800,000 last year or something like that.
Yeah,
If you include,
that's about that.
yeah, refugees, student visas, etc.
Everything,
That's
all the names.
1.1 million between temporary workers, new immigrants that became permanent residents,
And that is insane.
asylums, asylum seeker, which is at 50,000. They don't count the 250 that are on waiting lists, which should be counted. And then with student visa, you're looking at 1.1, 1.2 million.
So essentially, we do not have a welfare state now, because the government has said, we're promising to do all this for you. We're gonna take care of you and educate you and do X, Y, and Z, but they can't deliver because they're inviting all these people in. So that's what we need to focus on and say, okay, come on, politicians, figure this out. Do we have new people coming in? Do we have open borders, relatively open borders, or not? Because you're making your decision about access to care by default. You're pumping in a whole bunch of new people, and we can't even take care of the Nikos, Robs, and Chris's of the world already.
Yeah. So in other words,
so Shawn, you're racist. Okay. Cool.
No, I'm just bald. I'm just bald. I'm not
Yeah.
racist.
So basically what you're saying is we're making healthcare decisions without realizing we're making healthcare decisions.
So by
We're
default.
thinking and one of the things we say here is we don't really have a housing crisis. We have an immigration crisis or an immigration issue. And you know, that's a different topic, and there's some nuance there. But the gist of it is our immigration policy affects every other thing in Canada, and we seem to act like they are separate and distinct issues. And our policymakers are not really understanding that when you're making immigration policy, you're actually setting healthcare policy.
Right.
I did
We
have
had
one
a-
final. Sorry, go ahead.
We had a problem even if we have zero immigration. Just to be clear, there are problems in our housing industry, both with just the industry itself. There are problems in the healthcare industry, and we can talk about how it's being looked at and managed. So it's more than just immigration, but immigration just breaks the camel's back.
Yeah, that's a great point. And you know, like I was saying earlier, we you know, it's in this current moment, it's almost impossible to even talk about something like immigration because of the politics, and that's, you know, that has to change if we're ever going to fix any of these things. I had a quick follow-up, Chris, and then I think I'll be done. Just to what you said something earlier about newcomers, how they tend to, once they realize it's free, they tend to keep coming a lot more. I'm sure you don't have any numbers to back this up. I'm just asking you for your sort of gut feeling as someone who's in the system. On a average basis, would you say the average newcomer or immigrant, migrant, refugee consumes far more resources, healthcare resources per capita than the average native-born Canadian, or are they about equal?
You won't be surprised to know that nobody's done a study on that, right?
Because they're afraid of the answer, right?
Well, exactly.
And that's why I know you wouldn't be able to give me hard numbers. I'm mostly just a gut.
But I have number of years of experience of this now, and talking to my colleagues and whatnot. What I can tell you is, particularly, I think, and again, you guys would know better than I would, but I believe our biggest source of immigration right now is India.
Yep.
And,
40%, 40 to 50%. Yep.
Not even close.
And it's a cultural thing there, but they're big healthcare consumers. When you get a cold, you kind of expect to go to a doctor and get tablets. You know, as they say, they're Britishized. And when you have heartburn, you expect to go to the doctor and get tablets and whatnot. And so I get a common visit for me in one of the clinics I work in would be a young gentleman who's been here from India for maybe a year or two, who comes in with his list of, and I'm not kidding, 25 things that he wants to get checked for his blood tests, right? Oh, I get my blood tests twice a year, and here's all the blood tests that I get. This is from my doctor back in India telling me what you need to do. And it might be $300 or $400 worth of blood tests. And that's really challenging because, and Shawn and I could talk more about this, but the data says that if you're a 25-year-old guy and you're pretty healthy, you don't really need to go to a doctor.
Need those things.
Stay away from a doctor till you're 40 or 50. That's probably your best
Agreed.
health, right?
Is healthcare almost a status symbol in India, do you think? Like, is
somewhat, yeah. So it's a bit of a caste thing. We're not getting Indians and who come from the lower caste and poverty are not getting here. It's the ones with enough money and connections to come. So we're getting the richer Indians, and yes, for them, getting regular healthcare is just part of the normal way that they do things, starting at age 20 or not. So they're, in my experience, they're very consumptive of healthcare resources. They show up in the emerge a lot with coughs and colds and minor injuries that you guys would, as a Canadian growing up in Canada, if you tweak your ankle playing basketball, it's not too bad. I'm not going to go and waste doctor's time, but they do. They want to know because they think there may be some treatments or things that they need. And it's not to shit on that culture. It's more to say that it's a different culture and it doesn't fit with our healthcare where it's free. They pay over there. A young gentleman who saw me, he tweaked his knee playing squash when he was at home in India. He said within half an hour he was in a clinic. With another half hour he had an MRI. With another half hour he's back at the doctor. MRI is fine. It was just a tweak. No big deal. We can't do that here. Our system would break, but that's the expectation that they come with. Yeah.
So you can't tell them, like my mother told me when I was young, just throw some dirt on it, stop being such a bitch.
I haven't been to an ER in like 10 years or a doctor for that matter.
Yeah, that's interesting. Where'd they do your sex change? I'm just kidding. Shawn, did you want to answer his question? Did you want to answer
that was fully colored. I got that in a week.
So I'm going to let Chris own all the weight of that very spicy question you asked, and yeah, all the views can go towards Chris. I'll just simply say I'm not going to name any culture, but in Southern Ontario, we have lots of different cultural communities. They tend to hang together, right? We're a multicultural nation, right? You don't become Canadian. You stick to your culture. And so in the emergency department, you can almost tell who's coming in the door. Oh, it's one of those people, because you can hear them screaming and yelling. Or you go to another person who's literally dying in front of you. And the only way you can tell is they're getting really pale and they're talking less until they pass out on the side of the stretcher. So huge cultural differences, but you guys are socially inappropriate. I mean, you're not supposed to ask these kind of questions. The liberal view of society is we are just all the same. All humans are equal. Yep. Yeah, every culture's the same. But in reality, that's not true.
Well, of course not. Like, well, Chris, what you were saying, like, like you said, it's not that anyone is better. It's just different. And I don't understand why we can't just understand it like that. Of course, they're going to have a different culture. They grew up in a completely different country with different history, different everything is different. It would be insane if they came here and perfectly fit in. So, but we can't even talk about that because immediately, even though we're just talking about differences in culture, the woke left will immediately accuse you of talking about superiority of culture. And that must be frustrating for guys with your kind of sensibilities to kind of see some of these issues. And we all know you can't say it. Like, we all understand instinctively what you can and can't say.
Absolutely. No, and I will say too, like healthcare, we were woke when woke wasn't cool yet.
Yes.
Healthcare has swung very far to the left over many years. My wife Julie has written about this, and I wouldn't have dared done it, but she wrote about the feminization of medicine, which has occurred like something like almost 60% of
that sounds
medical school graduates have been women for about 20 years. So there's, medicine is a patriarchy. Probably true in 1975. It probably wasn't very true in 1985. By 95, it wasn't true at all. And now it's actually very feminized.
Just look at the study out of University of Ottawa. University of Ottawa.
What does that say?
It's something above 60%. I'm pretty sure that it's more than 60% now of students in medicine, not just nurses, but doctors, surgeons, whatever, name it, is 60 and over % women.
Wow. Yeah.
Yep.
Yeah. And not even, and I mean, I feel like you could have a feminized culture that's still being done by men, right? Like, it's not necessarily about the sex of the people. It's about
Justin Trudeau.
Just look at Rob. I was going to say Rob, but
you fucking guy, man. Jesus Christ.
Justin Trudeau wasn't.
But Justin Trudeau is a great example. Just even listen to the guy talk. You're like, shut the fuck up, man.
Yeah.
Like, grow up here. No wonder your wife left you, man. Holy shit.
Can I irritate you guys once, but you're wanting to end this segment, but you've mentioned imaging a few times, x-rays, that sort of thing. So I encourage your audience to check this out. CBC actually reported on a 2017 Manitoba Auditor General report on MRI wait times. And they found that athletes can get an MRI in Manitoba the next day. Quote, government officials, donors, or people working in the healthcare system got an MRI the same day or the next day. Workmen's compensation patients got an MRI within 20 days. And guess what? Regular people got their MRI in 23 weeks. Yep. So 23 weeks versus next day. CBC 2017, Google it, Manitoba Auditor General report on MRI wait times.
Chris is raising his hand. I like
yeah,
it.
I love that. I love that.
This one, because this is a non sequitur, but a wrap up comment, because I wanted to mention it, going right back to the beginning about this poor young guy who died waiting. I think, like, I start off by saying people are going down the wrong road in their way of thinking and approaching it, and it's going to turn right into we need more funding, we need bigger ERs, and this and that again. And trying to fix a problem in bureaucracy, trying to find somebody who's responsible. It's kind of like boxing with the cloud. Like, you can punch and punch and punch, but you don't hit anything because it's so diffuse. Who's responsible for this? The answer is, well, nobody knows. You can't really name somebody, and what's gonna happen is that I can predict what'll happen. There'll be an inquiry. They'll look into it. They'll say that the nurse made a mistake and the doctor should have recognized this and that. And that. They'll throw a couple of people under the bus because they love to do that locally, because it takes heat off the fact that when you have an emergency room full of people who don't need to be in an emergency room, most of them don't need to be in an ER, but they have no other care options. You've created this haystack that the people who are actually sick are these needles in big haystacks of people who aren't all that sick, because they're stuck. They don't want to be in an ER with their little cut on their finger. They love to just go to their family doc's office and check in and get it taken care of, but they can't. And so we're going to get into the weeds of this one particular issue. They'll throw people under the bus, problem solved, and everything will carry on like it always was, because we're not looking at the deeper problem, which is that it's a huge top-down, inefficient, managerialist system that just doesn't work.
So, Chris, when you say, like, just one final one, Nico, and then you can wrap up there. We were just saying there, like, it's a diffuse, like, you can't, there's nothing firm to grab onto. There's no one really to blame. It can always be deflected. Would you say this is a feature, or is this a bug? Is this intentional?
I've written about this before. I think for the people who are at the top of this and who
they probably love it.
Great. It's great. Like,
wash their hands.
How are you ever going to pin it on somebody? I was the regional head of ER in Nova Scotia for my part of my end of Nova Scotia at one point. And I found out after a while, I used to joke with people that the job had a lot of responsibility and no power. And I mainly felt like I was a cushion between the public, who was extremely dissatisfied with the long waits, and the people in charge who actually held the purse strings and whatnot. I tried to make changes. I wanted to make changes. I would advocate, we can change this and things will be better. We can change that, will be better. At every turn, there would be some lawyer or some person a couple layers up from me and say, you can't do this, and here's why, because the rules say X and Y and Z. And basically, the system is just stuck in this terrible repeating thing where every month we'd have a case that went sour because of a wait time. Somebody would die, somebody would have a bad outcome, somebody would complain, but I couldn't do anything about it. So you have all these managers in the system who aren't allowed to manage anything. They were like me. They were just frustrated and saying, throwing their hands up and saying, why am I here? Why am I called a manager? Most of them, I wasn't really paid for it. I wasn't, that's a long story. So, and eventually I gave up, and that was fine. But a lot of the managers who are in these positions, they realize they're useless, but they're making $90,000 a year in benefits. So they're not exactly saying, yeah, I'm out of here, I'm useless.
That's how they suck you in, right? I mean, it's pay to play.
Golden handcuffs.
Since you asked a question to Chris, I'm going to ask one to Shawn, because I think that's right down his alley. And that's one of our commenters. I absolutely fucking love this question. Free Wi-Fi saying, would you guys say healthcare is to Canada what the right to bear arms is to America?
That's more of a political question, but I'd like to hear.
I like it. So I don't know, Shawn, if I got a feeling that you have an answer for that.
Yeah, we've defined it as what it means to be Canadian. It's really the only thing that means. But there are two Medicares. There's the Medicare that exists in our dreams, the dream that we'll get care when we're sick. And then there's the Medicare that exists when you actually get into the hospital. And only 4% of any population, so pick your region, actually needs acute care services in a given year. So 96% of the people are living on the dream. We are literally living on the dream of Medicare because we don't experience the reality of it. And most of those 4% who actually need to go to hospital are sick and old and not very articulate, and they can't come and advocate for themselves. So you only have the rare patient, like you opened the show with, who has a family that are articulate and they're willing to, get lawyers and sue people. That's a tiny, tiny sliver of Canadian society. And most of the 96% don't want to admit that maybe our dream isn't real. And so, yeah, great analogy.
Yeah.
The
Sorry, go-
one thing I would really take issue with in the comment, I understand it, and it's a great comment. I agree with it, but it mixes up two things: negative rights versus positive rights. The right to bear arms is what's called a negative right. It's the right to be left alone. Look, I have a gun. I use it for hunting. Leave me the hell alone, government. Right? That's leave me alone thing. The positive right is this idea that I have the right to get health care. I have the right to walk in, and I have the right to get something from somebody else when I want it. I have the right to food. I have the right to housing. I have the right to clean. It's a right to something as opposed to the right to be left alone.
The 2A doesn't give you a free gun, kind of thing.
Yes, right. So in a way, I understand the comment in that it's sort of it defines who we are as a people. But one's a negative right and one's a positive right. And I think that's very telling of the difference between Canadians and Americans.
That's
Americans want to be left alone to live their life and make their own way and make their own wealth. Whereas Canadians want it to come from the government. They see the government as the provider of all good things.
Spoonfoot. Yeah, and we've talked about our high tax rate a lot on this show, and as one thing that I was saying the other day is that comes with a certain social contract. Like, I think most Canadians have this feeling like, okay, yeah, we're highly taxed, but in return, I expect a functional healthcare system, right? I expect holes repaired in the roads, good healthcare, good education, those sorts of things. And I think the perception is that the social contract Canadians have with their government has been broken.
A great quote that's very apropos to that. I believe it was Thomas Jefferson who said, "A government powerful enough to give you everything you want is also powerful enough to take everything you have."
100%.
Yeah, brilliant.
We're gonna end this here, but I wanted to finish with the wise guy's comment saying that before they leave, I want to thank those two guests. Very informative and entertaining. Enjoyed every bit. So you guys, and there's
this was a lot of fun. We've never had two guests at once. We weren't sure how it was going to go, but it went perfectly.
There's another comment that was saying that Prairie was saying that she would love to actually touch all of her bald head for good luck. So on that note, I want to thank both of you guys. Thanks, Chris. Thank you, Shawn, for being on the show. Hopefully you'll accept to come back, because we're always so you guys know,
experts if a new issue comes up.
We have a bunch of people that we call on, like they're experts in their field. So when there's something trending, there's something in the news, I like to call back on people on short notice to have them on the show. So if you guys are interested, I'll contact you after by email to see if you like the experience, or you're going to tell me to politely fuck off, which is okay. I'm used to that too. I'm used to that too.
As long as Rob's not on the show, I'm good.
Exactly. But I want to thank both of you guys. I don't know, Shawn, did you have a closing comment?
Yeah, anyone who calls me Baldy, man, I'm not coming back.
Wow. Guess what, Baldy?
Yeah.
I'm really going to work on losing all my hair before.
Yeah, you got to. Then
I agree.
I'm well on the way.
You'll fit in.
I love it. Great show. Great show.
Thanks so much, guys.
Thank you.
Appreciate your time.
Bye-bye.
Great guys.
Well, there you have it. Oh, yeah, this was really cool.
Yeah, that was a lot of fun.
This was definitely cool.
Yeah.
What do you guys think in the audience? Do you guys enjoy this? It's
that might be one of my favorite interviews, most enjoyable interviews we've done.
He made a very valid point though at the end. Even Shawn is like, damn.
That negative and positive rights thing?
That is, I've never thought about that. Is brilliant.
That's and just and who was it that said that? Was it
free Wi-Fi? It was a great question, by the way.
Yeah,
it is. Because it was a great one.
And I took that as a political comment. It's a political issue. Like I thought he meant like
from both sides. Yes, from both Canada and the U.S. Yes,
it's the third rail that government won't dare touch, kind of thing. And in that regard, I think he's right. Absolutely. And it's kind of alluding to what you were saying when you said, we're so socialist up here, we're never going to get rid of our healthcare system. Even conservatives up here, I don't think. I suspect a majority would want to keep them. It'd be a lower majority than liberals, but I think it'd still be a small majority that would want to keep it. It's an untouchable thing in the way that the 2A is an untouchable thing.
It's really one of those things that I just see it as being part of the culture in Canada. But
yes,
like Shawn was saying, you can't have open borders where a welfare state. That is oh man, that's what happens when you speak to people that are more intelligent than you.
Yeah, that's right. Eh?
You tend to hear shit. You're like, what the fuck?
Wow. Yeah.
But it's true. You can't live. You cannot have open borders and a welfare state at the same time. That's brilliant.
And that's how like policymakers need to be thinking about this. Like he's saying, we think we're making immigration decisions, but we're actually making healthcare decisions. We're making housing decisions. We're setting housing policy and healthcare policy when we actually think that we're setting immigration policy. And that just seems like a recipe for disaster. They're not considering any downstream effects. It's just the left has convinced everyone that immigration is always an inherent good
in a vacuum.
There's no downside to it, and if you disagree, you're racist.